Thank you, Ron, Christina, and Valerie for all what you are doing for 4-H and for having set up the Yaya Foundation. I just mentioned that we really need the boost families give us to our research, because we all, of course, have the same goal for your children, for our patients. Geneviève Bernard has already introduced 4-H, and I will continue. It's more a pensive talk because I see also a lot of other patients with hypomyelinating leukodystrophies. So this talk will also focus on the 4-H patients who do have hypomyelination. So not on the patients with the basal ganglia disease or the patients without hypomyelination. And that's the most frequent form of 4-H. So I just try to control the screen, but yesterday it worked, but now it doesn't seem to work.
If you click one time on the slides for us.
Yeah, I just.
There we go.
No, now it. So there are my disclosures. I don't think there are conflicts of interest, at least not from industry for 4-H. Now, just to tell you where I'm from Amsterdam, the Netherlands, and I'm working there in the Amsterdam Leukodystrophy Center, which was founded 20 years ago by Maya van der Knaap. And we were focused very much on MRI analysis, definition of new leukodystrophies, identification of the causal genes. But now we are shifting our focus a bit on natural history studies, so to understand and know about the natural evolution of a disease from disease manifestation until adulthood. We also look at tissue of patients. We have many patients or many families donating their brain after they passed away, and that helps us to understand disease mechanisms. We also have animal models for some of the leukodystrophies to better understand disease mechanisms, but human brain tissue is also very important. And then in the last 2 or 3 years, we have set up own treatment trials and participate in multi-center treatment trials of leukodystrophies. So the focus has shifted a bit from diagnosis to treatment, and that's of course a wonderful development, although it's not for all patients and certainly not for all leukodystrophies, but there has so many there has been so many changes for treatment and new approaches, new thinking, new possibilities, new techniques, that this is a very gratifying situation. So we care for patients with all leukodystrophies in our center, but we have a research foci, and we are 3 PIs, principal investigators for leukodystrophy. Maya van der Knaap mainly works on vanishing white matter, MLC, and Mark Engelen on X-linked adrenoleukodystrophy and other peroxisomal leukodystrophies. And my focus are hypomyelinating leukodystrophies, mainly 4-H and Pelizaeus-Merzbacher disease, and metachromatic leukodystrophy. And those are also the frequent disorders within the leukodystrophies. So Dr. Bernard already told you about normal myelination, which starts already in the womb and is completed around the age of 2 years. And that has been known for more than 100 years now. And we can actually, what happens is, and you heard a little bit on that already in Dr. Bernard's talk, myelin is the insulation material of nerve fibers. It consists of fat, a lot of fat, and also some proteins. And myelination is the process of making myelin and wrapping that myelin around the nerve fibers, which are very long and very thin and very fragile. So the myelin is really needed for protection of those nerve fibers, for nourishment of those nerve fibers, because you can't get all the nutritional factors from the neuronal cell body along a nerve fiber, which is sometimes more than 1 meter long, certainly in my husband, who is very tall. Myelin is the most abundant part of the brain white matter and often affected, usually affected in leukodystrophies. So myelination is actually something which happens in a very controlled manner. We have those myelin-producing cells, which we call oligodendrocytes, and they develop through certain stages until they are myelinating those nerve fibers. And that's something where you need all the cell types in the white matter. You need, for example, astrocytes to provide certain factors to start the process, but also fatty acids to make the myelin. You need other cells called microglia who make, again, factors promoting myelination. You need the axon, the nerve fiber itself, because the nerve fiber itself makes some molecules who again induce the oligodendrocytes to make the myelin. You need, of course, some glucose, thyroid hormones, iron coming from the bloodstream. And all that works together to make myelin. And that makes it a very, very complex process. And also very impressive for me is that this oligodendrocyte makes those huge sheaths of myelin within only a few hours, and it increases its surface by a factor of 6,500. And that's enormous. I mean, no other cell in the human body does that. And you saw it already in Dr. Delors' talk. Nowadays, we can follow myelination nicely on the MRI. And you see here from birth to the age of 2 years, how the white matter signal on the MRI changes. And in hypomyelination, where you have a deficit of myelin, actually the MRI looks very much like the MRI of a healthy newborn. You see that child with 4H at the age of 5 years, and a normal child at the age of 2 years, and that newborn. And you see that those two resemble each other very much. So we need the MRI to make the diagnosis of hypomyelination. So when I started my pediatric and pediatric neurology training in 2000, there was mainly one hypomyelinating disorder known, and that disease is called Pelizaeus-Merzbacher disease, or PMD, and it's caused by genetic variants in a gene we call PLP1, and that encodes the most abundant myelin protein. So that's also very logical. You have a defect in a myelin protein, so you can't make much myelin, you get hypomyelination. And actually, the typical image everyone had in his head about hypomyelination were children with a severe neurological disease, wheelchair dependency, spasticity, so stiff muscles, balance problems, cognitive symptoms, greatly reduced life expectancy, and a typical eye movement disorder with wobbly eyes. So that was what everyone thought hypomyelination would look like. And when you see children with different forms of hypomyelination, many also have a quite severe neurological involvement. But in 2000 and in 2002, I saw the first patients with what is now called 4H leukodystrophy. And I was very much surprised because those patients actually were able to walk, to climb stairs, although they had some balance problems. And now we even know patients with hypomyelination who have a normal neurological examination. And when I told this to the then most experienced doctor in hypomyelination, a colleague in France, she said it's impossible. It can't be that a child with such an MRI is able to walk. But it was really the case. And what we've learned actually in the last 15 years is that those hypomyelinating leukodystrophies are very heterogeneous disorders. There are many of them. And in the Netherlands, Pelizaeus-Merzbacher disease is the most frequent one, but the second most common hypomyelinating leukodystrophy is 4H leukodystrophy. And we saw now, I think about 60 patients with 4H in Amsterdam, and most of them have the typical hypomyelinating disease. But actually in the last 2 years, I've seen more patients without hypomyelination and so having the other forms, especially the severe basal ganglia form, than new patients with 4H leukodystrophy. But what you also see is there are a lot of very, very rare diseases where we know sometimes worldwide only 3 or 4 patients with this kind of hypomyelination. And you can imagine that that makes it not easy to work on those very rare diseases. So we thought actually that like Pelizaeus-Merzbacher disease, we would find in many patients with hypomyelination actually genetic variants in structural myelin proteins. That's true for about 1/3 of patients with hypomyelination, that those proteins in the myelin sheath are affected. But what we actually also learned is that more patients actually have variants in proteins involved in protein synthesis, which we call translation, and also transcription, which is 4H. So many genes involved in hypomyelination are actually important in the synthesis of new proteins. And why this is so important for myelin and the brain white matter, actually we haven't really understood well. I sometimes think it may have to do with the fact that this oligodendrocyte has to increase its surface by such a huge factor, and it needs to make so much protein in a very short time that this puts enormous stress on this very finely tuned machinery. And if there is a little bit of a problem through a mutation, that might impair that process. I don't know whether that's true, but it's at least a hypothesis. What we actually found in 4H leukodystrophy, when we look at the patients who have hypomyelination and we correlate the MRI to the clinical presentation, we see that it correlates actually quite well with the degree of hypomyelination. So we made a score, and we did that together also with Dr. Bernard and Dr. van der Ver and a colleague from Heidelberg, Dr. Harting, and we actually looked at the degree of hypomyelination and also the degree of atrophy, so volume loss in the brain. And we see that that correlates quite well with motor function. And you also see, and that's something I will show you a bit more about it in the next slides, we see that volume loss in the brain actually quite significantly increases with age. And we can see that when you see that brain here and that brain here, you see here a lot of more of white, which is brain fluid, which means that a brain tissue has been lost over time. That's a very slow process, but it's there nevertheless. You already heard about the atypical forms. I won't talk a lot about it, But I think it's important to keep in mind that 4H leukodystrophy is not only a white matter disorder. We have involvement of cortical neurons and certainly of neurons deep in the brain, which we call deep gray matter. So it's a very broad spectrum, and probably certain genetic variants lead to certain forms. Dr. Bernard already has mentioned that we know that for some variants, but for many others, it's still unclear how genetic variants lead to certain disease forms. So the clinical evolution, and that is for all hypomyelinating disorders, I know, so also for patients with Pelletier-Merzbacher disease, you have patients who do quite well for a long time, who are still able at the age of 20 years to walk without support, and then they slowly deteriorate and lose walking, sitting, even head control, and that's paralleled by a slowly progressive volume loss on MRI. Some patients have that much later. So I know patients who are 50 years old and are still able to walk, but some patients develop that even earlier. When you think back of patients with Pelletier-Merzbacher disease, for example, who start at a much lower level, many patients with Pelletier-Merzbacher disease than 4H, most of those patients are not able to sit without support. They also show that deterioration for example, they lose head control, they lose the ability of swallowing effectively. So we see that in other hypomyelinating disorders, and all patients develop mild atrophy over time. And that's something we know about it. It's an ongoing slow, what we see in young children, they do develop, many 4H patients achieve the ability to walk without support, but then they have a very long stable phase, and often, not always, but often from their teens, sometimes earlier, sometimes much later, they show deterioration. Loss of walking, if walking was achieved, swallowing problems, all the complications of impaired mobility, like scoliosis of the back, loss of active speech, fatigue, and I also have patients who have episodes of pain or chronic pain, especially patients with hypomyelination. I have not encountered that in other leukodystrophies. And we think that this probably has to do with slowly accumulating axonal damage, because imagine if you don't have this protective layer of myelin, those very long, very thin axons are exposed to all kind of stress and also don't get normal nutrients. And that probably will accumulate over time until the axon just can't keep itself up and gets lost. And we think that this is at the basis of the atrophy and the slow deterioration. And the question is, why do the axons do so well or relatively well for such a long time? And why do they at some point start to deteriorate? And could we actually prolong this stable phase for some time, and how? And this is something I think is not specific to 4H leukodystrophy. This is something I hope we can learn also from other hypomyelinating leukodystrophies, because that would give us not a causal treatment, but perhaps one day a possibility to stabilize white matter. And also if we have relatively much myelin, for example, in mild Pelletier-Merzbacher patients who are able to walk, who have quite some myelin on the MRI, they also develop that deterioration. So to increase the myelin a little bit, I'm not so sure how much change that will make on the long run. Of course, I hope it does, but in our idea, you need really good myelin to protect the axons optimally. So to conclude, 4H leukodystrophy is relatively frequent among the rare disorders among the leukodystrophies. In the classic hypomyelination presentation, clinical severity, if you look at best motor development, is related to severity of myelin deficit, and that is comparable to other hypomyelinating leukodystrophies. We have the same finding in Pelizaeus-Merzbacher disease. Patients develop first and then are stable for a variable time, and most of them deteriorate slowly. And also this is comparable to other hypomyelinating leukodystrophies. The mechanism of this deterioration is still unknown, but we think it's a slowly accumulating axonal damage, and the implications for general treatment are also still unknown. I would like to thank all of you for your attention. All of my international collaborators, especially Dr. Bernard and Dr. van der Ver, the hypomyelination team in Amsterdam, Fifi Heine is working on a stem cell model for 4H leukodystrophy. And of course, I think the Yaya Foundation, patients and families and colleagues from around the world, and many others who help.